In 1965, two neuroscientists, Ronald Melzack and Patrick Wall, published a paper in the Journal of Science that changed everything we know about pain. It's called Pain Gate Control Theory, and it's one of the most cited papers in the history of medicine. Here's what they discovered. Pain does not travel freely from your body to your brain. It's actually regulated at a specific location in your spinal cord by a neurological gate. And it's pictured here, so we're going to go into this a little bit more. This is the back part of the spinal cord, and it's called lamina 2. This gate sits in an area, again, called lamina 2. It's on the dorsal horn of the spinal cord, which is back here. Think of it this way. It's a relay station where pain is coming from the body and can be amplified or sent to the brain, and it can be blocked or suppressed before they ever get up to the brain. What controls that gate? It comes from two different inputs. You're going to have your C fibers that are small. You're going to have your A beta fibers as well, and A delta that come in. So what actually opens the gate are your pain fibers. These small, slow, unmyelinated C fibers and A delta fibers carry pain signals, or what is called nociception. And these signals associate with damage to tissue, and it associates with danger. So when these fire heavily, they push open the gate, and the pain goes up, and the brain registers that pain. So let's look at what closes the gate, and that's going to come from these A beta fibers. So mechanoreception, or mechanoreceptors, close the gate. They're your large, fast, myelinated A beta fiber that's going to come in from touch, pressure, movement, and position. When these fire, they activate inhibitory interneurons at lamina 2 that close the gate. Pain signal is blocked before it ever reaches the brain, so you don't perceive it. This is why when you get hit and you rub or bruise, it makes it hurt less. You're firing A beta mechanoreceptors. They race up to the gate ahead of the slower pain signal and partially close it before the pain arrives. This is why TENS units work at the spinal cord. The spinal cord stimulators also do the same thing. Ice can do it, massage. Every one of these therapies is exploiting the same gate. It's activating large fiber mechanoreception to suppress the small fiber pain signal, or nociception. This is also fundamental to why chiropractic works. Here's the critical piece that connects all of this to what we do as chiropractors. Your facet joints in the spine, the joints that we adjust as chiropractors, are among the most densely mechanoreceptor-packed structures in the entire human body. The capsules surrounding every facet joint are loaded with A beta fibers. Their entire job is to string position, movement, and pressure data up to the spinal cord and brain continuously. When those joints move properly, when they're not restricted, when they're not inflamed, and when they're not fixated, they are firing A beta fibers signals constantly. These signals are feeding the gate. The gate stays closed and pain is suppressed. When those joints stop moving properly through injury, degeneration, postural breakdown, or chronic stress, that mechanoreceptor input drops off. The A beta signals weaken, the gate loses its primary source of inhibition, the pain signals that are being filtered now go through. The gate opens and it stays open. Not because the tissue damage has gotten worse, it's because the gate lost its gatekeeper. Now let's talk about the second gate, your brain. Here's where it gets even more important. And this is the research that most people, even most clinicians, have never seen. The spinal gate is not the only pain control system. Your brain has a descending inhibitory pathway that works from the top down. You can see it here, coming down through this area. It starts in an area called the periaqueductal gray, or PAG. The PAG sends signals down through the brainstem and into the spinal cord that independently suppress pain. This is your brain's endogenous opioid system. This is why soldiers in combat don't feel their wounds, why athletes finish games on broken bones. The brain can turn pain off when it needs to. The periaqueductal gray, or PAG, is taught in every medical school. It is targeted by morphine, by deep brain stimulation. It's targeted by every descending pain modulating drug on the market. It's not fringe science. Now here's where research shows what happens to the system in people with chronic pain. A 2025 study published in the Journal of Pain, which is the flagship journal of the International Association for the Study of Pain, used MRI spectroscopy to directly measure the neurochemistry of the periaqueductal gray in chronic low back pain patients. What they found actually was very alarming. The periaqueductal gray showed a significantly lower excitation or excitatory to inhibitory ratio compared to healthy controls. The brain's pain off switch was chemically dysregulated. It had lost the ability to send robust inhibitory signals to the spinal cord. Other research has gone further. Brain imaging studies show that chronic pain patients have measurably less gray matter volume in their periaqueductal gray. The brain's pain suppression center physically shrinks in people with chronic pain. This is what we mean when we say a patient or person has a bad brain. It's not an insult, it's a neurological reality, and it's been documented by MRI. A brain that has been in pain distress long enough starts to lose the hardware required to suppress that pain. The result? Pain that persists long after the original injury should have healed. Pain that spreads, pain that responds to things that shouldn't hurt, not because the body is broken, but because the gate has lost its gatekeeper.